Kanski lecture series Uveitis part 2, and in this part we are going to study about the investigations. Investigations are often negative with no clear underlying cause determined in many patients. Rather than performing a battery of screening tests, investigation is tailored to each patient, directed by clinical features. Sometimes a likely cause may be obvious, such as severe anterior uveitis following intraocular surgery, when endophthalmitis will lead the differential diagnosis list. So basically, there are multiple investigations that can be performed in case of a uveitis, but these are tailored individually on the clinical signs and symptoms, and sometimes the history is so evident that you do not need such investigations to be carried out. In most cases, a careful review of systemic symptoms is essential to detect any clues to underlying disease, with referral to the specialist physician for further assessment when appropriate. Many associations of uveitis can present with a wide range of systemic features. Investigations is generally not indicated in the following circumstances: a single episode of unilateral mild to moderate, no hypopia, non-granulomatous acute anterior uveitis with no ocular or systemic suggestion of underlying disease. Typical clinical features of a specific entity for which the investigation is not usually indicated, for example, Fuchs uveitis syndrome. A systemic diagnosis compatible with the clinical features, for example, diagnosis has already sarcoidosis has already been confirmed. So basically, in these circumstances, we do not tend to do investigation. Firstly, that there is a diagnosed systemic disease, and you know that the symptoms signs of the uveitis are because of that diagnosed disease. Second is that there is typical clinical features, like in a case of a Fuchs uveitis syndrome. Second is when there is a single episode of uveitis, which is usually mild and there is no hypopyon. Situation in which this investigation of anterior uveitis is generally appropriate include recurrent acute anterior uveitis, severe acute anterior uveitis, bilateral. So remember, severe, bilateral, recurrent. Anterior uveitis that is persistent, chronic, or resistant to treatment. Granulomatous inflammatory signs. Note that a granulomatous condition may give non-granulomatous acute anterior uveitis. Associated intermediate or posterior uveitis. Ocular or systemic clinical features suggesting underlying disease. Repeating targeted previously negative investigations several years later is sometimes helpful. The following investigations should be considered: HLA tissue typing. The major histocompatibility complex MHC is a group of genes involved in a white cell antigen interaction and other immune functions, including the encoding of the cell surface glycoproteins. So basically, there is an HLA B27 association with the case of a uveitis. So what is that? Basically, there is a group of genes known as major histocompatibility genes, which are involved in white cell antigen and other immune functions, and also it encodes the cell surface glycoprotein. In human, the MHC found on chromosome 6 is called human leukocyte antigen system. So MHC, which is found on chromosome 6, is called HLA. HLA typing is used to determine organ transplantation compatibility and can also indicate predisposition to particular disease. It has conventionally been performed by the serological antigen identification, but increasingly involves the analysis of DNA. HLA B27 is common 6 to 8% of white in the USA, 0.5% of the patient of a Japanese ethnic origin cell surface protein that present peptide to the T cell. So basically, there is an HLA B27 association with the uveitis can be as well, and these are almost 8% in whites and 0.5% in Japanese. The phenotype has a very strong association with acute anterior uveitis, ankylosing spondylitis, and some other inflammatory conditions such as reactive arthritis, Rite syndrome, psoriatic arthritis, and arthritis in an inflammatory bowel disease. So there is certain condition which is pair that has been associated with. psoriatic arthritis. A is for ankylosing spondylitis, I is inflammatory bowel disease, and R is for Retter's syndrome. It is present in 50% of the patient with acute anterior uveitis who are otherwise fit and well, and 90% of the patient with acute anterior uveitis who have an associated spondyloarthropathy, notably ankylosing spondylitis. Many HLA-B27 subtypes have been identified and their significance is subject to ongoing investigation. HLA types associated with ocular inflammatory disease are listed in table 12.4. HLA-B27 testing should be performed in any adults or child with recurrent or chronic non-granulomatous anterior uveitis. So next is that you can do also the syphilis serology in case of uveitis. Whenever there is a suspicion of the syphilis, like what are the tests that require this identify syphilis? It's a troponemal antibody test such as ELISA. Enzyme linked immunosorbent assay are highly sensitive and specific, but around 3 months to take positive. So basically there is a TPA test which include ELISA system, and it is very highly sensitive and specific, but it takes 3 months to become positive. Next is a non-specific titratable cardiolipin antibody test such as rapid plasma reagent or a venereal disease research laboratory are more commonly positive in early infection are used to help monitor the disease activity. These tests become negative over time. Typically in treated disease, false positive result can occur. So basically you can also get RPR done or VDRL done for the detection of the syphilis, but it has a high chances of false negative and false positive rate. Both categories of tests should be performed when screening for ocular syphilis. Clinical features suggesting a diagnosis of syphilis should prompt urgent referral to the physician specializing in infectious or sexually transmitted disease. So this table is showing us the examples of the HLA association with uveitis. So there are certain HLA which has gives certain types of uveitis. So what the HLA B27 gives the recurrent acute anterior uveitis. A29 gives a bloodshot retinochoroiditis. We will discuss it in the last of this topic. HLA B5 and HLA B5 51 and B5 Bassett syndrome. So B for B51 and B5. HLA B7 and HLA DR2 is for the presumed ocular histoplasmosis syndrome. HLA DR4 and HLA DR4 both for the sympathetic ophthalmicus and Vogt-Koyanagi-Harada syndrome. Serum angiotensin converting enzyme is a non-specific test that indicates the presence of the granulomatous disease such as sarcoidosis, tuberculosis, and leprosy. Elevation occurs in 80% of the patient with acute sarcoidosis but may be normal during remission. In normal children, serum ACE level tend to be higher and diagnostically less useful. Vigorous exercise can elevate ACE level. So ACE level is very helpful in detecting some granulomatous disease, mostly sarcoidosis, tuberculosis, and leprosy. Then there is a lysozyme can be done. Lysozyme is a group of enzymes found on a polymorphonuclear neutrophils and numerous secretion including tears. It has a strong antibacterial action, mediating breakdown of the bacterial cell wall. Serum lysozyme assay is slightly less sensitive and specific than serum ACE in the diagnosis of sarcoidosis, but performing both tests may increasing specificity and sensitivity. So lysozyme is also for the condition of sarcoidosis, and you can perform both of these tests. If both of these tests are positive, it means that the patient is having a sarcoidosis. Then there is erythrocyte sedimentation rate, ASR and C-reactive protein, acute phase reaction that are probably of limited value but may be elevated in a range of systemic inflammatory disorders. So basically it is a marker of inflammation. If there is these are increased, this means that there is systemic inflammation that is being going on. Then there is a complete blood count. Leukocytosis may raise the suspicion of infection, and exceptionally hematological malignancy. Eosinophilia may occur in a parasitic infection. Lyme disease. Serology may be considered particularly in endemic areas. Serology for other infectious disease such as brucellosis and leptospirosis can be requested if relevant risk factors are present, for example, endemic region. Anti-nuclear antibody limited use except in children. In those with juvenile idiopathic arthritis, its presence is associated with higher risk of chronic anterior uveitis. Cases of possible subclinical GIA have been reported in NA positive children with chronic anterior uveitis. So basically, in a case of a juvenile idiopathic arthritis, it is basically of the value that it can tell you about the prognosis of the disease. So those with the NA positive have a, uh uh, poor prognosis. Anti-neutrophilic cytoplasmic antibiotic limited use in the anterior uveitis and unless associated with scleritis or peripheral ulcerative keratitis with cytoplasmic ANCA testing should be considered in evidence of a vaginal granulomatosis. So in a case of eye, you must remember C ANCA, which is for the vaginal granulomatosis, and basically it is also associated with PUK and scleritis. So whenever there is a uveitis with PUK and scleritis, you should go for this antibody test. Then there is an interferon gamma release assay, quantiferon TB blood test for tuberculosis. HIV serology for indicated for selective patient, usually those in which opportunistic infection has been diagnosed or is suspected. Sarcoiliac joint X-ray may show evidence of the cycolitis in ankylosing spondylitis and other seronegative spondyloarthropathies. Chest X-ray may show evidence of a sarcoidosis or tuberculosis. A high level of suspicion for both of these treatable conditions as well as syphilis should be adopted, particularly if the inflammation is granulomatous. Ocular imaging, B-scan ultrasonography. If the posterior segment view is compromised by very small pupil or opaque media, you can do B-scan. Optical coherence tomography (OCT) may reveal posterior segment complications such as cystoid macular edema and epiretinal membrane. So OCT can determine these things. Fundus autofluorescence may demonstrate suspected posterior segment pathology such as lesion of the several inflammatory conditions such as multiple evanescent white dot syndrome. So basically, idiopathic cases of uveitis involving the retina macula is the FFA is very important. So which may give a mild inflammation and often shown more effectively than on clinical examination. Fluorescein angiography is useful in some cases of anterior uveitis, such as confirmation or exclusion of the suspected posterior segment pathologies, for example, vasculitis, white dot syndrome, or identifying macular ischemia as the cause of reduced vision if no macular abnormality is visible on OCT. Indium cyanide green angiography is rarely indicated in anterior uveitis but might be used to look for subtle associated choroidal pathology. Ultrasound biomicroscopy is particularly indicated in case of hypotony and may demonstrate pathology such as subtle choroidal effusion, cyclodialysis, cleft, and cyclitic membrane. Aqueous tap. Historically rarely performed in anterior uveitis, but viral causes are now recognized as being more frequent than previously recognized. Herpes virus, including cytomegalovirus and rubella, should be considered in clinically suspicious cases, especially unexplained hypertensive uveitis and cases relatively unresponsive to the topical steroid. An aqueous humor sample may be sent for polymerase chain reaction analysis for evidence of a viral genetic material and for microscopic culture and antibodies assay. PCR may also be helped to exclude propionibacterium infection in a chronically inflamed pseudophakic eye. So basically, we can send PCR for the cases of when there are suspected virus like herpes virus, and when you suspect the viral etiology, you can also send the PCR for viral aqueous humor tap for the PCR analysis for like viral genetic material culture and antibody assay. And especially in a case of a pseudophakic eye, when the eye is chronically inflamed, you must suspect the propionibacterium infection for the chronic endophthalmitis. Iris biopsy is rarely performed. Vitreous biopsies tend to be confined to the investigation of obscure posterior segment inflammation and suspected infectious endophthalmitis. To determine the cause of persistent and severe posterior uveitis of unknown etiology for which all the workup is negative, consider undertaking a vitreous and or retinocoroidal biopsy. Next is a conjunctival biopsy. Conjunctival biopsy sampling of the tissue such as suspected granuloma or infiltrative lesion is occasionally indicated. Referral to a specialist physician with resultant further investigation. This is vital when systemic disease is suspected. For instance, if respiratory symptoms are present, a chest physician may arrange an additional testing such as high resolution computed tomography, CT chest scan, a whole body gallium scan for case of sarcoidosis, a purified protein derivative skin test for tuberculosis. Negative test is a diagnostic indicator in sarcoidosis and bronchoscopy with lavage or biopsy. Similarly, neurological referral may lead to a cranial magnetic resonance imaging and lumbar puncture and gastroenterological referral to endoscopy. So basically, you can also refer to the patient if you suspect the other causes, like if you suspect like STDs and there are some you suspect sarcoidosis, you can give it to for the neural physicians and other for imaging as well. Next is for the journal treatment of uveitis. So how do you treat with the uveitis? Remember, the uveitis is treated with mostly with the steroids, topical steroids, systemic steroids, periauricular steroids. Mostly the steroids is the treatment of choice. For patient with a treatable cause of inflammation such as infection, specific treatment is given either instead of or in addition to the general anti-inflammatory measures discussed below. Review frequency is set according to the severity and the chronicity of the inflammation. Patient with severe inflammation may need to be seen within a day or two of initiating treatment. Those with mild recurrent idiopathic acute uveitis may not to be seen for several weeks of the treatment is commenced. So basically, first you have to rule out infectious etiology and give the appropriate treatment. If the infection has been ruled out, you can give all other types of anti-inflammatory to control the inflammation of the uvea. So number 1 is the topical steroid. Prednisolone 1% or dexamethasone 0.1% is commonly utilized as a first choice. So mostly the potent steroids are used in a case of a uveitis like prednisolone or dexamethasone. Other preparation of a varying availability geographically include dry flu prednate 0.05% may be administered at a lower frequency, loteprednol etaponate 0.2 and 0.5% moderate to marked potency but a lower tendency to elevate IOP, betamethasone, prednisolone 0.5%, fluoromethalone and remoxilone. The later three are of moderate to lower potency. So basically these are of lower potency drugs, FML, remoxilone, betamethasone, and whereas loteprednol is having a moderate to marked potency. The selection of a topical steroid, and these are the most potent ones. The selection of the topical steroid preparation can be modified according to the severity and other factors such as known tendency to IOP elevation. So there is a chance of having a steroid induced glaucoma after the use of a steroid. So one should keep in mind about this. So you treat with the low potent drops if the patient is known to have a IOP elevated. Steroid or ointment, for example, betamethasone, may be instilled at bedtime to supplement the drops, and additional anti-inflammatory treatment is necessary in some cases. Treatment of acute anterior uveitis initially involves the instillation at a frequency appropriate to the severity of the inflammation, typically starting with 1 drops orally in moderate to severe cases. Once the inflammation is controlled, the instillation frequency should be carefully tapered. A commonly adopted regime might consist of 1 drop only for 3 days, then every 2 hours for 3 days, then 4 times for 1 week, then 3 times for 1 day for 1 week, then twice a day for 1 week, then once a day for 1 week, and then stop. Treatment is often discontinued for 5 to 6 weeks. Usually the steroid are given like for 3 days you give 1 orally drops, then other 3 days you give 2 orally, then 1 week you give 4 times a day, then other week you give 3 times. You are just tapering it. Another you just 2 times a day, and then 1 time a day, and then you stop. And this almost takes 5 to 6 weeks for the stopping of the treatment. Periodic reviews undertaken as appropriate during the treatment course, with further assessment a week or 2 after cessation, following which the patient can be discharged, but caution to re-attend urgently should symptom recur. Treatment of the chronic anterior uveitis is generally targeted at complete suppression of inflammation with no AC cellular activity or flare. The latter is now thought to be an indicator of active inflammation in most or all cases. Even low-grade ongoing activity is associated with greater incidence of complication that outweighs the risk of complications from treatment. Exacerbations are initially treated in the same way as acute anterior uveitis, though with more gradual tapering and typically a maintenance regime. Fuchs uveitis syndrome is an exception to this approach. So basically, you have to know that chronic anterior uveitis, you just stop the treatment. Your target achievement is that there is no inflammatory activity, like there is no AC cells or there is no flare, and flare is usually associated with the risk of the complications. Common complications of the topical steroid include transient elevation of IOP in a susceptible individual steroid responders. So one thing of the steroid is that it elevates IOP, so one should always be careful about that. Long-term treatment may lead to permanent IOP elevation with glaucomatous damage. Cataract can be induced, and cataract is another factor which can happen, but is less common with this than with the systemic steroid administration. So basically, topical steroids are more commonly associated with glaucoma, and systemic steroids with the case of cataract. The risk increases with the dose and duration of the therapy. Corneal complications are uncommon and include secondary infections with bacteria and fungi, and recrudescence of herpes simplex, keratitis, and corneal melting. Systemic side effects are rare with topical steroid but may occur following prolonged administration, particularly in children in whom measures to reduce systemic absorption such as medial canthal pressure and blotting away of overspill from eyelid following installation should be discussed. So, drops should be uh, given like if there is a minimum absorption in the systemic system. Next is that after giving topical steroid, you can give cycloplegic agents like to induce mydriasis, so that there is no formation of the posterior synegy. They are used in acute anterior uveitis and in exacerbation of the chronic anterior uveitis to prevent the formation of the posterior synegy. It can also be used to break down recently formed synechies and to promote the comfort by relieving spasm of a pupillary and the ciliary muscle. Commonly used anticholinergic agent in order of increasing potency and duration of action include cyclopentolol duration 12 to 24 hours, homoatropine 3 days, and atropine 7 to 10 days. So basically the duration of action for the cyclopen is 24 hours, whereas atropine is 3 days and atropine is homoatropine is 3 days and atropine is 7 days to 10 days. In the acute stage, phenylephrine 2.5% or 10% may be used to supplement anticholinergic and break posterior synegy. In mild or chronic anterior uveitis, a cycloplegic can be instilled at bedtime to prevent difficulties with accommodation during the day. In children, care should be taken to avoid systemic toxicity as a range of systemic adverse effects have occurred, including seizures. Prolonged uniocular cycloplegia may induce amblyopia in the susceptible age group. Then there is a Bitrican number 2. Basically, this is the subconjunctival injection which is given to release the posterior synegy and break down the posterior synegy. There is a preparation containing adrenaline and atropine that is used to break the fresh posterior synegy when drops are ineffective. It also contains local anesthetic to improve comfort. So basically, it contains of 3 components. It contains number 1 is a lignocaine, number 2 is atropine, and number 3 is adrenaline. Constituent quantities vary according to the manufacturer, but 0.3 ml containing 0.12 milligram adrenaline, 1 milligram atropine, and 6 milligram procaine is typical. It is usually administered by the subconjunctival injection. An alternative to injection is insertion of the cotton pledge soaked in mitricaine into superior and inferior fornix for 5 minutes. Serious cardiovascular events have been reported following injection. A transient sinus tachycardia is common. The patient should be monitored for injection. After injection, mitricaine number 1 is pediatric version that may also be effective in adults. So basically, The injection consists of 0.3 ml, which in which the 0.1 ml is lignocaine, or what you can procaine of what you can 6 milligram, and then there is a 0.1 ml of atropine, and then there is a 0.1 of the adrenaline, about 0.12 milligram. And basically you can also give it subconjunctivally, and also can give just soak the gauze pieces in the midricaine, and then you place it in a superior and inferior cortex for 5 minutes. Tissue plasminogen activator in severe fibrinous interior uveitis, 12.5 to 25 microgram of TPA in 0.1 ml injected into the AC intracamerally with the 30 gauge needle under topical anesthesia will dissolve the dense fibrinous exudate and may break down recently formed posterior synecdoche. Antiseptic precautions similar to those for the intravitreal injection should be taken. So whenever there is a very high fibrin content and there is a hypopion in the AC, what you can do is basically inject a 0.1 ml of TPA, which contains 12.5 to 25 microgram, and you inject it under topical anesthesia into the AC. Subconjunctival steroid can be administered in severe cases or to patient in whom poor compliance is likely. For example, betamethasone sodium phosphate solution 4 milligram in 1 ml can be given alone or in combined preparation with betamethasone acetate suspension for a sustained effect. For example, celestone 6 milligram in 1 ml. So you can also give in addition, when there is a lots of inflammation, subconjunctival steroid, and which dose is almost about 1 ml, and you can give 1 ml of betamethasone, or you can give 1 ml of a celestone. Then there is a regional steroid injection which is known as posterior subtenon. Basically you give this injection to reduce the inflammation of the vitreous inflammation, and there is a lot of vitreous inflammation is going on. The use of inferior approach, orbital floor or posterior subtenon injection of depot steroid preparation. For example, triamcinolone acetinoid, methylprednisolone acetate, TCA basically is common in the treatment of the posterior segment inflammation. So whenever there is a posterior segment inflammation, means the vitreous is inflamed, there is a cystoid macular edema, then you can give this posterior subtenon. But is generally reserved for the uveitis patient for the treatment of the cases complicated by cystoid macular edema and for the patient non-compliant with the topical administration. Periauricular injection may also be administered at the time of surgery and may rarely be used to supplement systemic therapy, or when systemic steroids are contraindicated. The peak action is about 4 weeks with the maximum duration of action for around 3 months. So basically the posterior subtenon injections likely to work after a month, and it will have its remain effective for 3 months. Complications include subconjunctival hemorrhage, globe penetration, refractive elevation of IOP up to 25%, cataractosis, eyelid hemorrhage, eyelid ischemia, necrosis, retrobulbar hemorrhage, subdermal fat atrophy, extra ocular muscle paresis, optic nerve injury, retinal and choroidal vascular occlusion, and cutaneous hypopigmentation. So these are all the complications that can occur with the case of a posterior subtenon injection. You can just penetrate into the globe, you can have a ptosis, cataract, hemorrhage, and you can have optic nerve injury as well. Systemic adverse effects are rare but can occur. Gives injection procedure. Table 12.5 gives the injection procedure. There is no clear evidence of the superiority of the one route over the other, but maybe of lower risk of ocular perforation, of raised IB, and of ptosis with orbital floor approach. Utilizing a plastic intravenous cannula via subtenon route have been described and is thought to offer a lower risk of perforation. So sometimes you can also use cannula to catheter cannula to basically do the subtenon injection. So this is the procedures in written table Procedure for inferior transseptal and posterior subtenon regional steroid injection. So, number one is the inferior transseptal orbital floor injection. A topical anesthetic such as tetracaine, amitrocaine is instilled to prevent stinging by the antiseptic agent. The skin of the lower eyelid and maxillary area is cleaned with antiseptic agents such as alcohol swab or povidone iodine 5%. So what you do is, firstly you have to put the local anesthetic eye drops, and after that you clean the area with the povidone iodine and alcohol swab and maxillary area. The vial containing the steroid is shaken. 1 ml steroid, triamcinolone acetate or methylprednisolone acetate 40 mg per ml is drawn up into a 2 ml syringe, and drawing up a needle replaced by a 25 gauge or um, 5 to 8 inch 16 millimeter needle. So basically what you do is, basically you take in 2 ml syringe and you take 1 ml of the triamcinolone, and after that you replace the needle with 25 gauge. The patient is asked to maintain gaze straight ahead. You ask the patient to look straight ahead. The needle is inserted through the skin. Some practitioner inject via the conjunctiva at the approximately the junction of the outer third and inner two-third of the lower orbital rim. Entry goes to the bony margin while clearing the margin itself. So what you do is, basically you just insert, you can do it via over the skin or you can do it in the conjunctiva. So at the outer one third and medial two third junction, you just put the needle into the orbit. The needle is slowly advanced tangentially or anatomy permitting away from the globe to similar fashion to a peribulbar local anesthetic block up to the needle hub. So you just inject it and quickly following the globe and like tangentially, and you basically you place it until you reach the maximum point. The skin may be indented to ensure the needle tip is sufficiently posterior to the deposit of the skin may be indented to ensure the needle tip is sufficiently posterior to the deposit the steroid away from the interior subconjunctival area. So you just put your pressure on the finger, indent your skin so that the needle also move inward, so that the steroid is deposited posteriorly. The tip may be felt to engage the bony orbital floor and to pierce the orbital septum. As with the superior injection technique, the needle may be moved from side to side to ensure the sclera has not been engaged. The plunger is slightly withdrawn, and if no blood enters the syringe, the full 1 ml is slowly injected and the needle carefully withdrawn. Special care is required in a patient with a large eye, for example myopia, to avoid the penetration of the globe. So this is the inferior transseptal orbital floor injection. Next is a posterior subtenon approach. A topical anesthetic such as tetracaine, amitrocaine is instilled. A small cotton pledget impregnated with tetracaine, lidocaine, lignocaine 2% gel or alternative is placed into the superior fornix at the site of injection for 2 minutes. So you just make a cotton swab that is usually soaked in anesthetic, and you placed it into the superior fornix for 2 minutes. The vial containing the steroid is shaken. The 1 ml steroid, triamcinolone acetonide methylprednisolone or 40 mg per ml, is drawn up into the 2 ml syringe, and a drawing up needle replaced by a 25 gauge or 5 to 8 inch 16 millimeter needle. So same as above. The patient is asked to look in the direction opposite to the supratemporal injection site. So you just ask the patient to look in front nasally. The pulbar conjunctiva is penetrated with the tip of needle bevel towards the globe, slightly on the bulbar side of the fornix. The needle is slowly inserted posteriorly, following the contour of the globe, keeping it as close to the globe as possible in order not to penetrate the globe accidentally. Wide side to side. Motions are made as the needle is being inserted and the limbus watched. Movement of the limbus means that a sclera has been engaged. When the needle has been advanced to the hub of the plunger is slightly withdrawn, and if no blood enters the syringe, the full 1 ml is slowly injected. A method utilizing a plastic intravenous cannula introduced via the same route following the conjunctival incision and limited blunt dissection has been described. So next is the intraocular steroid. Intraocular means the intravitreal steroid. Intravitreal triamcinolone acetonoid 4 mg in 0.1 ml. 1/10 of the orbital dose is occasionally used in anterior uveitis for the cystoid macular edema unresponsive to the other form of therapy and rarely may be considered at all at the time of intraocular surgery in a high risk anterior uveitis patient. Complications include elevation of IOP, cataract, endophthalmitis, steroidal infectious hemorrhage, retinal detachment, and pseudohypopyon. Slow release intravitreal implants may occasionally be indicated. So you can just put on the intravitreal triamcinolone when there is a not responding to other forms of treatment and there is a severe vitreous inflammation. The dose is almost about 4 mg in 0.1 ml. Next is you can also give systemic steroid, are very rarely required for anterior uveitis but may be needed when the response to topical treatment is inadequate. They are sometimes given as a short course prior to intraocular surgery as prophylaxis against worsening inflammation, having the advantage of rapid cessation of effect in comparison with the Dupont peri or intraocular steroid injection, but have major potential adverse effect. Next is non-steroidal anti-inflammatory drugs such as naproxen and tolmetin may be effective in chronic anterior uveitis and can be used in long term under appropriate specialist physician supervision. Antimetabolites such as methotrexates are generally not required in the treatment of anterior uveitis, though it may be necessary in exceptional patients such as juvenile idiopathic arthritis associated chronic anterior uveitis when other measures fail to control inflammation or as a steroid sparing measure. So these are all the basically treatment that can be used when the steroids are not working or steroids are contraindicated. In a patient with uveitis, it is important to ensure that there is no potentially life-threatening systemic disease present or an infectious cause for the inflammation. So that's it for the uveitis part 2. See you in the next lecture.